can I, Prof, thank you very much. It's very kind of you and the um, the PAUS as well as Aga Khan University to dedicate this session together with South School of Urology. So may I ask you to do the introductions and then start with the webliner. Thank you.
Thank you, Professor Nath. It's a pleasure to have this first joint meeting between South School of Urology and the Conceptual Basis of Urology course run jointly by Aga Khan University and PAUS. So it's a pleasure to be part of this activity. And I hope that participants from both South and from PAUS will benefit from this activity. So shall I start with my presentation?
Yes, please.
Okay. I hope my screen is visible.
Yes, sir.
Okay, great. So what I'm going to talk about today is strict stratification for the non-muscle invasive urothelial cancer. My name is Hamad Attar. I'm working as a professor at Aga Khan University in Karachi. And this is, as Professor Srinath just mentioned, is the first joint conceptual basis of urology and South School of Urology course. And it's a pleasure to have all of you this evening. So no conflict of interest related to this presentation. We all know that non-muscle invasive bladder cancer is a heterogeneous disease which has a very variable recurrence and progression potential. So the recurrence could be as high as 30%, as low as 30%, as high as 80% at 5 years, whereas the progression is hugely different between less than 1% to almost half of the patient would progress. So depending upon various other variables. So these variables which have been looked into includes the multiplicity of the tumor, age of the patient, stage, prior recurrence rate, carcinoma in situ, grade of the tumor, size, and gender. And some of these have been incorporated into various risk calculators or risk assessment tools. And if we look historically, these tools have been, the first one that has come was the EORTC in 2006. At the same time, the Spanish Club of Urology for Treatment of Cancer, Kyoto, in 2009. EORTC came up with the modified tool 2016 because of the changing practice pattern, the management of non-muscle invasive bladder cancer. And very recently, a few years back, the EAU risk calculator and the risk assessment tool was introduced. So we'll just have a quick look at these various tools. The EORTC 2006, reported by Sylvester in the European Urology, had over 2,500 patients, of which about 1,400, which is just over half of the patients, were primary. And the data was collected from 7 EORTC trials, and the time frame was between 1979 to 1989. The variables looked at for multiplicity, size, and prior recurrence rate, the stage of the tumor, the grade of the tumor, and the grade was assessed on the 1973 grading system. So based upon this, the Omni calculator was introduced and it was available for everyone to download. And that Omni calculator essentially looked at all these variables, and you can actually, for any given patient, calculate the risk for recurrence and progression. The EAU non-muscle invasive bladder cancer guidelines 2009 risk stratified the patients between low, intermediate, and high risk for both recurrence and progression. Now, we know that that time the BCG was not that easily available and used. So there was a very small proportion of patients who were treated with BCG. and majority were treated by intravesical chemotherapy. So the evidence summary for the 2006 risk assessment tool was that it is able to predict short and long-term risk of disease recurrence and progression in individual with non-muscle invasive bladder cancer when the grading is done on the WHO 1973 system. Few years later, the Spanish Club for Treatment of Urological Cancer, the Kyoto risk assessment tool was published in the Journal of Urology by Fernandez and Gomez. Over 1,000 patients, and over 2/3 of these patients were primary. And the data was collected from 4 Kyoto trials between 1990 and 1999. And if we look closely, BCG is now becoming the standard of care. So BCG induction and short maintenance is what was recommended at that time. So in total, between 9 and 12 installations of BCG were done in these patients where the data was collected. And the Kyoto confirmed that the prognostic value of EORTC 2006 model for both recurrence and progression was lower for all Kyoto patients, probably the effect of BCG, because the EORTC trial patients were less frequently treated by BCG. Similarly, the risk of progression was also low, again, probably the effect of BCG. So now we are seeing a changing pattern. The Kyoto trial has gender as well, whereas the gender was missing from all the other EAU trials. About 7 years later, the EORTC 2016 risk assessment tool was published by Combier in the European Urology in 2016. It has nearly about 1,800 patients, and of which 55% patients were primary tumors, not had been treated previously. Data was collected from 2 EORTC trials between 1992 and 2005. And the significant variables for recurrence were multiplicity and prior recurrence rate, whereas for progression, stage, and grade of the disease. And now, as we know that entering into the 21st century, BCG is becoming the standard of care. And particularly for high-risk patient, BCG became the standard. Not only the induction, but also the maintenance therapy is becoming more commonly used. So in this group of patients, the minimum planned 15 installation were done in about 40% of the patient. And a comparison between this and the Kyoto 2009 and EORTC indicated that the EORTC 2016 prognostic value of the 2 earlier models were reconfirmed, and they were lower for high-risk EORTC patients. Again, probably because of the progression rate was lower because of more BCG being used in the maintenance cycle as well. So at least 1 year BCG significantly impacted patients with a high-risk patient who were treated by it. Now, we still see quite a disparity particularly in the high-risk group, that they were high-risk group with higher progression potential, and need for cystectomy was also felt. And if you look at the older guidelines, there've been clear indication that de novo cystectomy prior to any BCG in some of the high-risk patient was recommended, whereas majority were treated by intravesical BCG. The EAU 2021 guidelines in trial was on over 3,400 patients, and they were all primary. The data independent patient data was collected from 17 centers using the WHO 1973 classification. Over 50% of the patients were after 2010. So the significance for progression was assessed again by the stage, CIS grade using the 1973 classification, and the size and multiplicity. The only available model that also uses the WHO 2004 and 16 system was also in this study. So the grade in primary NMIBC, not prognostic for recurrence. The 4 groups for progression were low, intermediate, high, and very high risk. So this is essentially a new thing which was introduced in the EAU 2021. Because as we have seen that in the high-risk patient, there is a category which responds very poorly to BCG. And this group needs to be identified so that specific treatment consideration will be made. Now, we know that over the years, variant histology has a significant impact on the progression potential. And these were something which was not incorporated in any of the previous risk assessment tool. Patients with micropapillary, neuroendocrine, plasmacytoid, and sarcomatoid differentiation with lymphovascular invasion and presence of carcinoma in situ in the prostatic urethra are all very high-risk patients. So a specific category was created which was very high risk. Primary CIS was considered as high risk. So now, since last 3 years, we have a classification system which is low, intermediate, high, and the new classification which is very high risk. Now, if you look at these tables, one on the left side of the screen, are the variables. And one thing which has been introduced in the 2021 risk assessment was the age factor. And barring age, all the rest were the same parameters which have been. The weight is defined in this table, and based upon these weight, if it is 0 to 80, the progression score would be low. If it is 85 to 150, is intermediate, between 165 to 305, high risk, and patients who have more than 315 score were considered as very high risk for progression. Now, if you look at the current EUA risk groups, the very high risk group have quite a significantly higher risk for progression of disease. And as a consequence, their separate identification was important. Just to recap, the low risk category is a primary single TA low-grade tumor, which is less than 3 centimeters in diameter without carcinoma in situ in a patient who is less than 70 years of age. The high-risk patients have high grade, either it is high grade or G3. Both systems have been used in this classification without carcinoma in situ. The very high-risk patients have various combinations which are defined here in the table, in which the 3 risk factors, which is age, multiple tumors, tumor diameter of greater than 3 centimeters. If all these risk factors are there with TA high grade, then it becomes very high risk and so on. So I'm not going into the details. They're all easily available for you to see. Tumor with the carcinoma in situ in the prostatic urethra, lymphovascular invasion, and variant histology are the additional risk factors for very high risk patients. So this is as for the risk assessment is concerned. And I think yes. So just a few examples to illustrate the point. This is a 79-year-old male, diabetic, hypertensive, ischemic heart disease, history of cabbage, valvular heart disease on warfarin, recurrent gross hematuria, MI about 9 weeks back, very poor anesthetic risk. A flexible cystoscopy showed a small low-grade cancer. Now, this is a situation that we all confront once in a while. And in this situation, the regular schema of care, which include treatment with intravesical treatment, followed by check cystoscopies and proper TURBT, is not possible in this patient. So the only thing that can be done is a flexible cystoscopy under local anesthesia with some sampling of the tumor. Now, for this group, does chemoablation has a role? If we look at the data, 4 to 6 installation of mitomycin C without a proper biopsy and without a proper TURBT is shown to have beneficial effect with a complete response rate of about 37%, biopsy proven, reported by Mustafid, and complete clearance in about 60% of patient on visual inspection on cystoscopy alone. If we have high compliance, there are very few adverse effects, and the 12-month recurrence-free survival was in 84% patient compared to the younger group with similar disease. What about active surveillance some of our patients? And it seems that active surveillance is also an option in patients who have a very high anesthetic risk and cannot really undergo treatment. So we are living in an era where our last category from 2006 onwards has been modified into 2 categories, which is high and very high risk. And with these, our treatment and follow-up of patient has really changed. And this is what is clearly there in the guidelines. And quite a few of our very high-risk group are advised an upfront cystectomy because the potential of recurrence and progression with BCG would be extremely high. And we know that patients who have had recurrence on BCG would do worse than the de novo muscle invasive bladder cancer patient. So it's important that some of these patients should be treated by cystectomy at an earlier stage. So I'll stop here. So thank you very much for your attention. I'll stop here, and then we can have some further discussion when Dr. Balagobi present some of his cases. So I'll unshare, and Dr. Balagobi.
Can you all see this the screen?
Yes, we do. So
Right.
our audience can write questions in the chat box, or if they want to ask a question, they can raise hand, and the host will allow them to speak after this presentation. Thank you.
Yeah, thank you very much giving this opportunity. And I'm going to discuss a case scenario of BCG refractory bladder cancer. So this patient, Mr. K, 72 years old, retired clerk with a diabetic with impaired renal function, presented with the hematuria and acute retention, which was managed with candida irrigation. Surprisingly, he's a non-smoker, but his father had a bladder cancer. And flexible cystoscopy revealed multiple small papillary lesions. And there was another 2 centimeter solid looking lesion at the right lateral wall, but with the narrow pedicle. So you can see the multiple papillary lesions looking like this, and there was a lesion at the left lateral wall. CT scan, no extravesical spread, no pelvic lymph node, no metastasis. So TURBT was done. Histology, sorry for this, not clear, but high grade PT1 and the detrusor muscle was present. So considering, as Prof. Ahmed said, so this patient comes to the high risk category. And so it was discussed at the MDT, and MDT said to do a relook TURBT. So relook TUR, there was nothing, scar tissues excised, and there was no residual tumor. So BCG induction started, and surveillance cystoscopy done at the end of 3 months. It was normal. Then the maintenance 3 doses started. But end of the 6th month, in a follow-up cystoscopy, there were 2 lesions, each about 1 to 2 centimeter, and histology was high grade T1. Now we have given almost 6 months of BCG. Now what to do next? It's a question. So I'm planning to discuss this scenario. I'm going to give an overview of non-muscle invasive bladder cancer and overview of the BCG therapy, and to discuss about BCG unresponsiveness and management of these particular patients, and discuss about the future directions. So as Prof said, the bladder cancer is the commonest urinary tract malignancy, and 75% of the bladder cancers are non-muscle invasive. So non-muscle invasive, as Prof said, 50% chance of recurrence and 25% chance of progression. It can differ based on the risk stratification. Contrast to this, the muscle invasive bladder cancer can kill the patient. If you take among the high risk non-muscle invasive bladder cancer, the 40% of that category are BCG unresponsive cancer. And we all know that BCG unresponsive bladder cancer can progress and kill the patient. So it's a life-threatening disease. So BCG is a live attenuated Mycobacterium bovine bacillus, and which comes as a powder. So there's a controversy about the dose. Traditionally, we use 81 milligram, and nowadays in the USA they use 120 milligram. And I heard some in India they use 40 milligram. So there's no proper guideline about the dose, and the guidelines say all the brands are same, but we need a detailed study or detailed guideline in how to add which brand and how much and how to give the BCG. But ideally 1.58 to 15.9 into 10 to the power 8 colony forming unit, it's important. Now how this BCG acts, it's bind the both normal and malignant urothelial cells via the fibronectin receptor, and which stimulate the cell-mediated immune response, T cells, and macrophage, and neutrophils. That's release the interferons, tumor necrotic factor, and interleukins, which kills the cancer cells and also reduce the proliferation of the cancer cells. Now, as Prof said, the low-risk cancers, single installation of MMC is enough. Intermediate risk, Either you can give MMC or BCG for 1 year. We know that MMC have less side effects, BCG have more side effect, but BCG is more effective. In high risk group, the BCG is recommended for 1 to 3 years, and the highest risk or very high risk, the upfront radical cystectomy is recommended. So there are different the BCG regimes are used. The well recognized one is a LAMP regime. So where the induction is weekly, 6 weeks of induction. Then there's a 6 weeks of free time. Then weekly 3 weeks of maintenance at the end of the 3 months or start of the 4th month. So then every 6 months, 3 weekly BCG installation. So that's about 3 years. But we have to make sure before starting the session, we have to do a surveillance cystoscopy. But no one agreed what is the correct regime, but this is one of the standard method. Now, why 6 weeks of induction? Because at the end of the 6 weeks, we get the peak immune stimulation. So like that, why 3 weeks of maintenance? Again, the highest immune stimulation is seen at the end of the 3 weeks during the maintenance. And if you see the BCG dose and response, which is a well-shaped, so if you give a low dose, less response. If you give high dose also, less immune response. So you had to give in a medium dose. So that's why we had to give the correct dose and the correct duration. So BCG, it's prevent the recurrence, and some studies shows it's reduced the progression in the high risk non-muscle invasive bladder cancer. So if you are not giving the maintenance dose of BCG for 3 years, we are not going to reduce the progression. Again, we know that TURBT plus BCG is better than TURBT plus chemotherapy with either MMC or ibirubicin or gemcitabine or interferons. And another point we have to remember is prior intravesical chemotherapy has no impact on subsequent treatment with intravesical BCG. So absolute contraindication, just think if there's a wound in the bladder, it can be post-URBT or traumatic catheterization, it's a contraindication. Or patient have a symptomatic UTI. Asymptomatic bacteria is not a contraindication. But if the patient have a immune deficiency or immunocompromised state like post-transplant, pregnancy, or methotrexate, then it's a relative contraindication. Now I'm coming to what is BCG unresponsiveness. As I told already, 40% of high-risk non-muscle invasive bladder cancer, they don't respond to BCG. But more than that, the main problem is more than 50% of the BCG responders develop recurrence either within 6 months or after 6 months. And we all have to remember, we all think after failed BCG, why we can't give one more BCG maintenance or induction. But more time we delay, there is a 6-7% risk of progression of the disease into the muscle invasive category. So these definitions are confusing, but just remember the BCG refractory is if you can't get a disease-free status by 6 months of the BCG treatment, or at the end of the 3 months, the tumor is progressing in the stage or grade, then we can say it's a BCG refractory. But BCG resistant is not severe like BCG refractory. It's end of the 3 months, you get a lesser degree or lesser stage disease, but that's get cleared with the 6-month treatment. BCG relapsing, there was a period of no disease, then subsequently they develop a disease, usually after 6 months. And BCG intolerance is due to side effects. So there's another definition. What is BCG unresponsive disease, which is basically combination of BCG refractory plus BCG relapse within 6 months. So that is a BCG unresponsive, because that's BCG relapse is more commoner than BCG refractory disease. Now, why there is unresponsiveness? It can be due to low BCG dose, or maybe the high BCG dose, or we have diagnosed the wrong disease. It may be a T2 or T3, but because of the understaging, we have labeled that as a T1. That's why the re-TURBT is very good when you have a T1 high-grade disease. Patient may have due to the patient factor can results in a less immune response, or maybe problem with the drug, dosage or delivery or the brand. Now, if you see the EAU 2024 guidelines, there is a new category called BCG exposed tumor. So what is a BCG exposed tumor is? If a high grade or CIS patient present in 3 months, evaluation of the BCG only, or there's a delayed relapse after adequate or inadequate BCG. Now, if you are treating a T1 high grade disease or CIS, and at the end of the 3 months, if you are getting a low grade disease or high grade TA, that's mean T1 now becoming a TA, high grade TA. Or if you have a CIS, now at the end of the 3 months, if you have a CIS, you can give one more BCG induction. There's a 50% chance of response. Similarly, in a T1 high grade, you give a BCG, at the end of the 3 months, you have a high grade TA rather than T1. Again, you can give one more induction of BCG, so there's a well documented response. So don't do a radical cystectomy. If you see at end of the 3 months, again a CIS or a high grade TA disease. That's why they have made this BCG exposed tumor category in a 2024 EAU guideline. Now, how we are going to manage, this patient who is BCG refractory? So according to the AUA, right? So this patient should go for a cystectomy if the patient is fit. But if patient is not fit or patient is not willing for radical cystectomy, then we have to use the other available intravesical chemotherapy, or we have to use a systemic immunotherapy. So they have to be enrolled in the clinical trials. Now, this is an important fact. So, I went to this bladder cancer symposium in 2017 in Italy. So there, one professor said, T1 G3 bladder cancer, it's like T3B, Gleason score 5+5, 12 out of 12 cause positive, PSA 75 prostate cancer. So it's a very, high risk bladder cancer. It's going to progress in near future. So in a highest risk, as Prof said, doing a cystectomy is known as upfront cystectomy. In patient like our patient, T1 G3, and we give BCG and BCG fail, then you do a radical cystectomy. It's known as an early cystectomy. But in this patient, our patient, you are not, patient is not willing for a cystectomy. You give other treatments like intravesical gemcitabine or any other systemic therapy. Then that's fail, and you do the surgery. That's a late cystectomy. But when the patient develops non-muscle invasive and you go for a radical cystectomy, it's known as very late cystectomy, which have a poor prognosis when compared to the upfront cystectomy. So a lot of new treatments are coming. They are in a phase 2 and phase 3 trials, but we had to wait for the outcome. But up to now in a EAU or AU guidelines, no new treatments are recommended. So in conclusion, BCG unresponsiveness is a challenging condition. The treatment other than radical cystectomy must be considered oncologically inferior. This is from EAU 24. Thank you very much. I think, Prof, we can discuss the question at the end, or you want to discuss now?
Yeah, if there are any questions at the moment, I have addressed a few in the chat box. So if there are any new questions, well, nothing.
This is Srinath, Prof. Gobi and Prof, can you just enumerate a bit about failure to continue BCG therapy? Not BCG failure, but we know that there's a very high dropout rate with BCG due to numerous factors. Can you just elaborate very briefly about BCG and its compliance?
Yeah, so the BCG side effects are very common during the induction. So if they can tolerate the induction very well, so they will proceed to the maintenance. But it's very common, more than 50% of the time, so patient stop taking the side effects, and sometimes it's very difficult to watch how they suffer with the cystitis and bladder contracture and all sort of infection. So it's very common, and Prof will have a more experience with this the compliance. Prof, over to you.
So the side effects from BCG is extremely high. What is recommended now is that first 3 days after each cycle, your patient should be on phenazopyridine and paracetamol to alleviate some of the symptoms, because it is these symptoms immediately after installation which results in significant dropout from the BCG. And we know that BCG for high-risk patient, dropout means that they can go on and progress, and that would really make cystectomy inevitable. The other thing is that decreasing the dose of BCG, and it's very clearly established that half dose BCG works as well with fewer side effects than a full dose BCG. The use of anticholinergics and all the other treatment to control symptoms are there. The delay in doing the next cycle is another factor. Patients typically would do much better if you reduce the dose. If you have a proper BCG cystitis, at least 1 month course of isoniazid and rifampicin is another option. So essentially, there are many tools, and EAU guidelines very clearly describe how to deal with various BCG-related complications.
So, Prof, I want to ask, this kind of situation, like this patient coming with BCG refractory disease, so how usually you manage?
So, I mean, if you look at the guidelines, very clear that BCG refractory patient in the high-risk category are the ones who should be offered upfront cystectomy. Now, the reason why this is recommended, and there are a few cases that I've also discussed in Slough meeting a couple of years back, in which the response, the overall prognosis of patients who are BCG refractory is worse than patients who have de novo PT2 disease or muscle invasive bladder cancer. So it's important that one should be very clear about advising cystectomy earlier than later, because late cystectomy invariably would result in metastatic disease, and they already have micrometastatic disease. So it's important that these decisions should be taken. So this is and obviously not every patient is comfortable, because we know that cystectomy is a life-changing experience. So there is significant resistance to cystectomy. There are options available. Pembrolizumab is one option. The use of interferon, and some of the other chemo and immunotherapy is available although the evidence is not strong and we still have only short-term results available for these things. So essentially, if the patient is willing, cystectomy is the answer. Thank you.
Can I add something?
Yes, please,
Amar
Dr.
sir, Amar sir, Madhu here.
Yes, Dr. Agarwal, please proceed. Thank you.
I'm sorry for joining late. I'm still stuck in the hour.
Yeah, I understand.
But I'd like to add one or two things. So firstly, we've been using low-dose BCG for many years now. We published our experience, a study of low-dose versus standard, intermediate dose and standard dose many years ago. And what we found was that the outcome in terms of effectiveness, responsiveness was nearly equal with low dose versus intermediate dose versus high dose. And it was almost 20 years ago. And ever since, we've been using only low dose, 40 milligrams BCG. And in India, almost everybody uses either 40 or 80 milligrams. Nobody uses 120. And the outcome is nearly the same. And as you said rightly, the side effects, the adverse events are much less. So that's one thing. Secondly, in BCG unresponsive cases, we have found very good results with the gemcitabine and gemcitabine docetaxel combination. So we've got not too many, but a fair number of patients who have demonstrated very good response to gemcitabine alone. And the literature says gemcitabine docetaxel has even better response, although we have a rather limited experience because of relatively high cost of this combination. So this is what I would like to add to what you've already said.
Yeah, I agree with what you've said, Dr. Agarwal.
Yeah, and
Thank you, Prof. Thank you, Prof. Madhu. Sorry to drag you out of theaters on a busy day, but it's very important that you join as the chairman of the South. So welcome, and I hope you'll be able to stay with us for the rest of the web lineup.
Yeah. Thank you.
Yeah, and Prof. Hamad, so if a post-transplant patient come with a high-risk disease, what do you give? Intravesical BCG or is it intravesical gemcitabine? So how will you manage that?
I think it's a very important question and a very interesting question. The issue here, what we are dealing with is our understanding of how BCG works. And since we know that the BCG essentially works by activating our immune system, and as a consequence, you mount an immune response against the bladder cancer. That's a very simplistic way of explaining how it essentially works. So your patient who has had a transplant is an immunocompromised patient, and their response to immunological agent would not be the same as that of immunocompetent patient. So in that situation, one has to be very careful in using BCG in this group of patient. Although the treatment would be tailored according to some of the other factors, but these patients should be considered for an extensive TUR followed by BCG, but very closely monitoring the response. And although we don't have a strong data to suggest that at what point in time you should consider them as BCG unresponsive, but if there is lack of response, these patients should be considered for alternative treatment.
Thank you, Prof. Can we move on to the next segment of the webinar? And I think it's again Professor Hamad who's going to deliver the next part of the lecture.
Thank you, Dr. Srinath. So the next talk is about the urinary diversion choices. We have talked about cystectomy, and what comes next is diversion. Again, no conflict of interest. This is Dr. Bernhard Birkenhauer, who was a surgeon in Cologne, Germany, and this is the Citizen Hospital in Cologne. And this gentleman is the one who performed the first cystectomy in a patient. So there is the so this was in the late 19th century. I think it was 1873. And there is a nice article written by Dr. Harry Herr in the International Journal of Urological History, published 3 years back, about the first Blasen extirpation, which is bladder removal. Now, this patient, after bladder removal, did quite well for the first few days. He had a totally obstructed left kidney. And because of the bleeding during prostate resection, doctor could not find the right ureter, and the right ureter could not be implanted in the rectum, which was the original plan. And as a consequence, the surgery was successful. However, the patient died because of uremia, as the ureter was draining into the pelvis. Obviously, we have progressed quite a bit since then. We know that the type of diversions that we have are either conduits, which are ileal conduit, the most common type of diversion, or colonic conduit, which are essentially transverse and sigmoid colonic conduits, or we have the continent diversion. And these continent diversion include both orthotopic new bladder or continent cutaneous diversion. Indiana pouch is one of the examples. The transverse colonic conduit is an option which is probably the most suitable one for short ureters. And this typically happens when you have CIS, or positive surgical margin, or positive frozen sections on your repeated ureteric resections. And in the end, you find that ureters are very short and they could not be diverted, or if there is radiation. And in all these situations, the possibility of doing an ileal conduit or orthotopic bladder is almost not possible. And transverse sigmoid diversion is the only option left. Similarly, sigmoid colonic conduits is another option, and we'll talk about it in a little detail. The transverse colon conduit is a more extensive surgical procedure in which the whole colon, the both ascending colon from cecum upwards and the descending colon, is mobilized along with the distal ileum. Once that is done, the omentum is removed or is dissected off from the transverse colon. And now you have a transverse colon which is available for diversion. You can have either this hanging below the colocolic anastomotic line, in which situation you will transpose your ureters from the mesentery and open them up into the colonic conduit, and or you can have it above the anastomosis in a situation where you have absolutely no ureters left, and what you have is only renal pelvis, and both the pelvis can be directly anastomosed to the transverse colon on either side, and the transverse colon can be opened on the skin. So this is essentially what you have, and in a situation where the ureter are extremely compromised, that is perhaps the only solution left. You have another group of patients in whom a colostomy is already done for previously because of either colonic cancers or some other reason. And in this patient, you can do a colon switch urinary diversion. So what you essentially do, if there is a transverse colonic or sigmoid colonic stoma, then you can use that part of the colon for urinary diversion and create a stool diversion a little proximal to it. And this is called colonic switch urinary diversion. There are some special, because colonic diversions are not very commonly done. It's important that we understand very special situation in colonic diversion. We know that the mesentery of the colon is large, but infrequent compared to ileum. And the blood supply is essentially dependent upon the arterial flow coming from the arc of the Drummond, which is arcuate arteries providing the flow to. We need to identify the watershed areas in the colon, and we know that the superior mesenteric and inferior mesenteric watershed, and the inferior mesenteric and the hypogastric mesenteric, the hypogastric artery watersheds are the two watersheds that you need to identify whenever you want to use a colon as your urinary diversion, incontinent diversion. When you're using transverse colon, it's extremely important that you completely mobilize the ascending and descending colon, release the momentum, and only then you can do a good watertight anastomosis, which doesn't leak. Move on to the next type of diversion, which is an orthotopic new bladder. I'm not going to talk about the continence cutaneous diversion. Indiana pouch is a classical example. So if you look at the Dutch, German, Spanish registry, between 10 and 20% of patients undergo an orthotopic new bladder, both for males and females. And we know that the emptying of these reservoir is essentially by abdominal straining and sphincter relaxation. Terminal ileum is the most commonly used bowel segment. This procedure is associated with significant morbidity, both early and late. There are various different types of orthotopic new bladder, which include the classical CAMI 1 and CAMI 2, followed by the modified Z-shaped CAMI 2, the cock pouch, which was the dominant one used for decades. However, because of the complexity and the complication rate, it is not very commonly used. The T pouch, which is a U-shaped reservoir, and probably the most commonly used reservoir, which is the Studer new bladder, is a U-shaped double-folded reservoir. The Houtman W and the modification of Houtman W by Abulanine and Gunim, the W-shaped bladder, and the VIP, which is the Vesica ileale Padova, the Italian bladders, which is a circular bladder. So these are some of the examples. I'm not going to go to the techniques. What are the main concern when we're doing orthotopic bladder? One of the major concern is because we are using an ileal segment where the anti-reflux anastomosis is not possible. Upper tract urinary reflux protection is extremely important. And various technical steps have been described, including simple isoperistaltic tunnel creation, which is classically in the Y bladder, and the Studer bladder, the ileal interception to try and prevent the reflux, the tapered ileal segment, and so on. However, clearly the ileum is not for non-refluxing anastomosis. This was a trial reported by Skinner unit, and it was a comparison between the Studer pouch, in which no attempt is made to do any anti-refluxing anastomosis. It's a Luduck type of end-to-side anastomosis on the ileal chimney, versus the Skinner's bladder and the T-pouch orthotopic bladder, and they found no difference in the overall upper tract morbidity in patients who have either Studer or the T-pouch. What about oncological outcome? Patients who have new bladder versus ileal conduit, there is no difference in the cancer-specific survival when the two groups are matched for pathological stage. Obviously, there is a concern about urethral recurrence with orthotopic new bladder. Again, the new bladder orthotopic urethral recurrence rate is extremely low, although it varies from less than 1% to 13%, but close to about 4.6%. The urethral recurrence rate is not very dissimilar from that patients who undergo ileal conduit. So essentially, these results indicate that new bladder, both in men and women, does not incur a poorer oncological outcome. So the functional outcome assessed by the upper tract and however, the most important thing is to properly select your patient for orthotopic new bladder. In our experience as well, about 10% of the patients essentially have an orthotopic new bladder. The rest would undergo, for various reasons, ileal conduit. You need to discuss all possible diversion types so that you change your decision on the table. Your patient is not upset. You need to look at the comorbidity, the tumor characteristics, the nodal status, and the patient preference as well. Some of our patients who are eligible for orthotopic new bladder because of the complications and need for revision surgeries, they would rather opt for ileal conduit. There are certain contraindications because some of these patients would require regular emptying of the bladder. They would require intermittent catheterization at times. So patients who have got debilitating neurological or psychiatric illnesses are a contraindication. Liver impaired patients, patients with renal dysfunction are again some of the contraindications. Patients who had radical cystectomy and an ileal conduit are essentially have long-term complications, all related to the urinary diversion. The cystectomy bit is mostly in the first 3 months, but after that time, all the morbidity is related to the diversion. So the diversion choice should be tailored very carefully because it is what will upset your patient on the longer run. Electrolyte imbalance, we all know that because of the reabsorption, if you do not have a good kidney function, your patient would have all metabolic abnormalities, and you need to be really aware of these metabolic abnormalities, particularly the hyperchloremic, hyperkalemic metabolic acidosis, which can occur if there is impaired renal function. The salt loss syndrome, again, is another factor. Metabolic acidosis with malaise and poor and ill health is again something that you need to be careful about. So ileal new bladder is probably the gold standard for a quality, from quality perspective. The technique is simple, standardized, and reproducible. The continence, if there is a proper integrity of the external sphincter is preserved, is very good with over 90% daytime and at least 80 to 85% nighttime continence in these patients. You have to make sure, however, that your reservoir is at low pressure and it does not expand. If your patient continue to hold urine for long, the reservoir becomes bigger and bigger, and then it would not be able to empty. So it's important that this major surgical procedure should be done with all the possible care to avoid long-term complications. The ideal orthotopic bladder or ideal diversion is still eluding us. It should be one which stores urine at low pressure, protect renal functions, allow complete volitional emptying, and is a socially acceptable continence. The diversion should have minimal absorption, acceptable rate of early and late complication. So no single bladder type is ideal, but perhaps my personal bias because of my teacher is towards Studer new bladder. Urs Studer, with whom I learned this procedure, unfortunately died year before last. and he was an outstanding urologist, a surgeon and mentor and a teacher. Thank you very much for your attention. Dr. Madhu and Dr. Srinath.
Yes, Prof, can we take any questions very briefly, because this is a fairly comprehensive talk. So can we take any questions, any comments?
Absolutely. We're looking into the chat box. Okay, so there's one question by Dr. Chandra Yadev about how to manage patients who have undergone radical cystectomy of the new bladder and have incontinence. Now, you need to assess why there is incontinence. Obviously, you made all the efforts of preserving the neurovascular bundle and their external sphincter. In that situation, the chances of continence is extremely high. You also need to remember that the bladder capacity should be close to about 400 to 450 ml, which would be providing optimum capacity, which would not result in incontinence and would result in complete emptying of the new bladder. So this would happen if you have a reservoir at low pressure and you have advise your patient to empty their new bladder every 4 hours by the clock. There's not going to be a desire to micturate. If you do develop incontinence, even with all these things, and it is because of the poor sphincteric function, then obviously options are very limited, including bulking agents or artificial urinary sphincters. The description of artificial sphincters in this situation is very limited, so very few people have experience of doing it in that setup.
So holding any further questions to till the end of the next segment, can I ask Dr. Balagobi to take on the next lecture, please?
Yeah, thank you again. So this is again a quite challenging condition for everyone. High volume, non-muscle invasive bladder cancer. So again, I am going to discuss this with as a case-based discussion. Thank you, Prof. Hamad, for giving the details about this patient and images. So here, 47-year-old male, heavy smoker, visible hematuria, no past medical history, and ultrasound scan revealed and the imaging revealed the high volume bladder cancer. And this was a CT image, a lot of cancer, the right lateral and posterior wall, and also in the dome. So first TURBT done, histology high grade PT1, retrousal muscle was present, and that was an incomplete resection. And second TURBT done, again high grade PT1, follow-up imagings revealed again residual disease. So what next? One more TURBT or TURBT until complete resection or intravesical chemoimmunotherapy or radical cystectomy or radiotherapy. Of course, that is not in the guidelines. I'm just asking whether to give a radiotherapy. So I'm going to discuss this scenario into two parts. One is how to resect this kind of tumors. It's very useful, very important for trainees and junior consultants. And then how to manage this particular patient. So this is very quite common. Sometimes you get a large volume tumor, challenging for everyone. Always see the preoperative images, CT scan very well. and see the patient factors, whether male or female. You all know that male have a thick bladder wall and females have thin bladder wall, more chance of perforation. And, you know, you have to discuss with your anesthetist what type of anesthesia they are going to give, whether it's general anesthesia is better, or either spinal with obstructional block, and discuss with your team, nurses, to prepare all the instruments and the supportive staff. I always prefer one more your colleague, whether it can be senior junior in the theater, so he, more brain and more hands, very helpful. So I think end of this session we have to discuss where to start, whether you will start at the dome or lateral wall or posterior wall. I prefer to start at the floor of the bladder, then move to the easy one. I start and move to other places. But some people say start in the dome because when you do a lot of resection, a lot of air bubbles in the dome disturb your vision. So that's a good question where to start. But I prefer to start from the easy side. Because lateral wall, there may be some obstructure. So whether you will start with a big tumor or small tumor, so I again prefer to start the small tumor, clear, then go to the big tumor. And so are you going to resect all the small tumors, or you're going to fulgurate the tiny ones? So whether you are going to use a monopolar, bipolar is a controversial. People say object and jerk is not much different, but that's again a discussion. And we are very careful with the diverticulum because we know there's no muscle in the diverticulum, tumor in the diverticulums. And the correct amount of filling of fluid. Too much, if you fill, thinning of bladder wall and more chance of perforation. And what type of resection you are going to do? Of course, very difficult to do en bloc in this kind of large tumors. And careful hemostasis, which resection of each tumors. And maybe you can keep one of your colleague to press in the tummy that make your resections in the anterior wall. It's easy. So to improve the TURBT resection, better to start with your virtual training on simulators as a trainee. There should be a supervised learning because TURBT is a challenging surgery. And the amount of your experience or volume of the number of surgeries you do decide your outcome. And better to have two checklists. One is for a TURBT procedure per se, and the pathology checklist. When you are resecting a papillary tumor, the exophytic portion in the one bottle, and the base of the tumor in another bottle, and the edge of the tumor in another bottle, different location of the tumors in different bottles, and do a good bladder diagram so everyone will understand. So the checklist about the patient, checklist about the TURBT, and checklist for a bladder cancer is very important. And the surgeon should have a good attitude to improve his the outcome about the TURBT, and there should be a good infrastructure, and we have to regularly do a audit on this. So there's research paper says the obturated nerve block improve the outcome of the TURBT, and more presence of detrusor in the specimen and reduce the recurrence. And in some centers, the urologist, he can do the ultrasound guided block, or you can get the assistance from your anesthetist. So assessing the quality of TURBT of a center is very important. So you have to consider three things. One is R node clearance. So that is assessed by recurrence at the end of 3 months, number of recurrence. Or when you are doing a re-TUR and number of missed tumors, that's indicate your performance with the clearance. The second indicator is how actually you have correctly identified the biological potential of the tumor, the correct staging of the tumor, in the presence of the detrusor muscle, then only you can label the risk group appropriately. The third thing is safety, avoid the complication. So two common complications are perforation and the bleeding. So Bruce Lee has said, I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times. So if you want to be perfect in the TURBT, do it the TURBT regularly and you become better, right? So risk of understaging. So, presence of muscle in the specimen is very important. The absence of the muscle, almost always indicate understaging of the tumor. So presence of the detrusor muscle in the specimen is very important. Of course, we know whatever situation you do a re-TUR, if there's a high grade T1 and or else you think is an incomplete resection, or there's a decision from the MDT. So there's a clear evidence that re-TUR reduce the risk of recurrence. Now, if you take our patient, he's having a high grade T1 and large amount of tumor, so multiple tumor. Diameter is more than 3, definitely, but his age is not more than 70, is 43. So, but except that age, he's fitting into the the highest risk of non-muscle invasive bladder cancer. So very high risk. Now, as Prof. Hamed said at the start, the very high risk cancer have a risk of progression almost 20% at the end of 1 year and almost 50%, 44 to 50% at the end of the 5 years. So there's a high risk. If you're not treating this patient properly, they are going to progress to the muscle invasive bladder cancer. So if you see the AUA, any guidelines, what they say. So if you have this kind of patient, highest risk, large amount of tumor, persistently positive tumor despite the multiple TURBT, the recommendation is radical cystectomy. I have already told this, the upfront cystectomy have a better outcome rather than the very late cystectomy. So again, so cancer specific outcome and the overall outcome is far better with upfront radical cystectomy. So in our patient, so in my opinion, it's better to proceed with radical cystectomy, and the surgeon factor is important. If the surgery was done by a trainee or junior consultant, then you had to discuss in the MDT and decide accordingly. Maybe one more TURBT for a complete resection. So that's the second patients, and we can discuss more about this because it's very important area for junior consultants and trainees. Yes, Prof. So if you get a large amount of tumor, you start with the floor of the bladder, or you start with the dome, or where you start?
I personally don't have a clear distinction of where to start, but typically I start from the floor because dome of the bladder bleeding is extremely bothersome and it tends to disturb your resection. So it's best to start from the floor, keep resecting, and then maybe go in the end to the dome of the bladder and side walls. So I try to do as much resection as possible, but typically what really happens for very large tumors that you have described, it is not possible and not safe at times to complete it in one go. And it's best to come back again to complete your resection. And I think it's in times safer. Thanks.
So, Prof, what kind of anesthesia you prefer? Is it you do under GA for the large volume tumors, or you do spinal with?
We typically do almost all our TURBTs under general anesthetic. They have a relatively better relaxation of the bladder, as you've described, that putting your hand and trying to go into unreachable areas of the bladder, the mobilization using your hand to bring that tumor closer to your resection loop is assisted by general anesthesia. And again, obviously, the obturator reflex is relatively less in general anesthetic, although it can still happen. But so for TURBT, and particularly for larger tumors, it is general anesthesia preference. For smaller tumor, again, general anesthesia, because most of these patients are daycare and they're going home. So the recovery time from regional anesthesia in the recovery room is long. So prefer general anesthesia for majority.
And do you see any different bipolar and monopolar resection in regards to the tumor? When we consider in the obstetric jerk or bleeding and the tumor quality for a pathologist?
I think the tumor quality is significantly affected by en bloc resection versus piecemeal resection. So obviously the en bloc resection provides a much better quality tumors for pathologists to assess compared to the piecemeal resection tumors. As for the monopolar versus bipolar is concerned, I have no experience, so I can't really comment on that.
Thank you, Prof.
Thank you, Prof. I think this was an extensive discussion of a very important topic. I'm conscious that we are running out of time, and I think in keeping with tradition, we need to close this session now. May I ask Professor Madhu, Chairman of SAUS, to speak a few words before we close? Prof. Madhu? Dr. Pawan? I think Prof is a bit held up. It is preoccupied in theater. So on behalf of SAUS, can I take this opportunity to thank both our extremely valued resource persons. I think Professor Hamad is he's a global authority on bladder cancer, and he runs numerous courses in different parts of the world. So we are very proud and privileged that you were able to share some of your knowledge and expertise with us, Prof. Thank you very much. And also thank you for making SAUS a part of your conceptual basis of urology course. So I'm sure this collaboration can go on to other areas as well for the benefit of urologists and trainees in Asia. Also, thank you, Dr. Balagovi. I know you too have had a very busy day today, and he's one of our foremost young and very bright urologists in Sri Lanka. Finally, I'm very pleased that we have had participants from different parts of Asia. We've had participants from Pakistan. We've had numerous participants. Almost all the trainees in Sri Lanka have joined, and I see India and Nepal as well. So this is indeed a great achievement, and we look forward to many of these interactions in the future. Thank you very much. Professor Hamad, before we close, a few words.
No, thank you very much. I think it's a wonderful collaboration, and we should really continue this tradition. And I'm really very happy to be part of this exercise. Thank you very much, Professor Srinath, Dr. Balagobi, and Professor Madhu Agarwal.
Thank you and good night.
Thank you. Good night.